Thank you for joining my presentation on asthma management of the pediatrics. My name is Terrence Shenfield, and I am the co-owner of A&T Respiratory Lectures, and I want to thank you for joining this presentation, and I hope that you learn a lot by the end of it. There is nothing more disheartening than to see your child have an asthma attack. This can occur at home, it can occur at school, it can limit their ability to play in sports, and there are many risk factors involved with asthma. You could have a genetic link, one of your parents have asthma. It also could be that some prenatal situations where the mom smoked or took certain antibiotics. So there's a whole host of environmental factors going along with asthma. So the point is, you have to recognize that your child has asthma, and then you have to also do something about it. At the end of this lecture, you're going to know exactly what to do for your child if they have asthma, how to keep on top of it, and you'll never see a picture of your child like this in the future. So just stay tuned, and I think you're going to enjoy what we're showing you. In today's objectives, we're going to be talking about how to identify a pediatric patient who's at risk for asthma. We're going to talk about assessing the severity of asthma, which is really important. You really need to understand what level of asthma you have based upon your symptoms. We're going to talk about the medical management of using stepwise approach. What that means is when you identify the severity of your asthma and you're on a treatment plan, you need to recognize when your asthma gets worse. And there's some objective ways that you can measure this. So based upon these objective measurements, you could step up your treatment regimen so this way you can maintain good airways. So if you don't maintain it, if you don't recognize it, and you don't step up your treatment plan, you're going to end up being in an emergency room. You have to be able to identify aggravating and precipitating factors. For example, many patients have triggers to dust mites. Some people have it to cold weather. Some people have it to cold exercise. Some people even have it to foods. So you really need to understand what aggravates your asthma, what you can do about it, and especially what you can do to prevent it. And then, mostly important, we're going to talk about understanding the necessity of parental and patient education. You have to educate the patient about their asthma. They need to understand their triggers. They need to understand medical management using a stepwise approach. They need to understand their severity of asthma. You need to understand all of these things to be healthy. So this doesn't just go for the parent. This goes for the patient too. And also it goes for your caregivers, like it could be for your brothers, your sisters, and so on. So understanding these objectives is very important, and I'm going to go over each and every one of them in more detail. So what exactly is asthma? Asthma can be defined as a chronic condition which is characterized by an increased responsiveness of the airways to various types of stimuli. When I use the word stimuli, think of triggers. When we breathe in various types of triggers, be it the fact of cold air, be it cigarette smoke, be it perfume, be it dust, or so on, our airway responds quite rapidly by forming some form of obstruction in the airway and inflammation. This inflammation can be reversed either spontaneously or it can be reversed by the result of using some kind of medication. Basically, it's all associated with airway flow obstruction. So basically, you have decreased airflow as a result of asthma. And one of the telltale signs of asthma, if you can reverse that inflammation and airflow obstruction by using medication, that typically tells you you have asthma. Now, how does a doctor define whether you have asthma? There's a few ways they do it. Number one, they could take a detailed medical history. So if your parents have asthma, you have some kind of genetic link to asthma, that's one way of doing it. They could also do a physical exam. They could also do a lung function test, which is sometimes a hallmark test. They also could do chest x-rays where they could actually determine whether you have hyperinflation. They also, at this point, they recognize some of the common signs of it is that you have coughing, you have shortness of breath, you have wheezing, and you feel chest tightness. Sometimes this could be an emergency where you end up going into the hospital. I have a sad story. I worked with a coworker who happened to have asthma years ago when I first started working as a respiratory therapist. And when she was my mentor, and as a result of working with her, I realized that she was taking her inhaler almost like every 2 hours. So we'd work together. Next thing I know, she would be going off and getting a nebulized treatment. And to tell you the truth, as much as I was a respiratory therapist, I graduated from a program, I never lived asthma like I did with her. I came into work one day and I found out that she had a severe asthma attack at the job and she died. I couldn't believe it. But the bottom line, I learned so much from that. From that point on, I decided to become an asthma educator. I understood more about it. And one of the telltale signs about asthma is that you cannot manage your asthma by a short-acting beta agonist. In other words, you cannot just take Preventol Q2 to manage your asthma. And we're going to get a lot more into this, but I'm going to talk a little bit more about inflammation, what happens to the airway in the next slide. But that's my personal story with this, and it was pretty, it made me aware of how severe asthma is. Let's talk about inflammation. Inflammation is one of the hallmark signs of asthma, and inflammation is a really, really bad thing. I have two images here. The image on the left, which is a normal bronchiole, and the asthmatic bronchiole on the right. I wanted to highlight some of the features. For example, under the normal bronchiole, what you have smooth muscle wrapped around the airway, and this is normal airway. Also, you notice that the radius of this area right here, in the middle of this right here, this area right there, is wide open. You don't have much inflammation of the airway walls. You don't have much mucus production. Now, well, let's go over to the one on the right-hand side. What happens is the pathophysiology of asthma involves the infiltration of inflammatory cells to the airway. These include neutrophils, eosinophils, lymphocytes, and all of these activate the mast cells, which causes epithelial damage. The hallmark signs of asthmatic inflammation is features of airway swelling. See all the airway swelling? You have increased mucus production. You have the muscles around the airway caliper are tight. They actually constrict the airway. And all of this leads up to airway flow limitation. Another real problem with inflammation, especially chronic inflammation, is a term called airway remodeling. Airway remodeling means when you have prolonged chronic inflammation, the structure of the airway changes. What happens is the airway typically gets fibrotic. It has increased mucus production. It has epithelial cell injury. It also has smooth muscle hypertrophy, and it has another term called angiogenesis, which basically means more vascular systems are produced in the airway, which increases production, and it also increases the fact of secretions in the airway. So you don't manage inflammation with albuterol. Let me repeat that one more time. You do not manage inflammation with albuterol. The only thing albuterol does, it relaxes the smooth muscle, this area right here. It has nothing to do with this area under here. And this is what you need to address. So that is why you need some form of steroid for these patients to manage, especially patients with severe asthma. So this is a little bit about the pathophysiology of asthma, and it gives you a little snapshot of what's going on. So how do we diagnose asthma in children? I want to first say that many children have been misdiagnosed for having asthma when they don't have asthma. So you really have to be careful. Some of the telltale signs of having asthma as a child is coughing, wheezing, shortness of breath or fast breathing, chest tightness. Also, these children, their symptoms get worse if they have some kind of viral infection, such as a cold, if there's smoke in the house, such as tobacco smoke or wood-burning stove, or there's some kind of strong perfumes. If they do some form of exercise or active playing and they get short of breath, that's another telltale sign of asthma. Sometimes children are allergic. They could be allergic to pollen or animal fur. Also changes in the weather, such as humidity or crying or laughing. All of these things can point to asthma in children. So the things you really have to look for is parental history. You have to make sure that mom or dad doesn't have a history of asthma. Also, atopic dermatitis. A lot of patients who have asthma also suffer from atopic dermatitis. So a lot of times if you manage atopic dermatitis, you could actually manage the asthma. Also, things you got to concern about are you have to rule out certain disorders, like I mentioned before, like a lot of children are misdiagnosed for asthma. You could have GERD, you could have some form of airway abnormality, you could have a foreign body in your airway, you could have cystic fibrosis, you could have vocal cord dysfunction. All of these things got to be ruled out to determine if the child has asthma. And a lot of times, pulmonary function tests cannot be done on children 5 years of age and under. And so that can represent a problem in diagnosing asthma. But one of the telltale signs, if the child responds well to a bronchodilator and anti-inflammatory medications, maybe they have asthma. If they have symptoms that occur worse at night, greater likelihood that is asthma. And as I mentioned before, if they cough, if they wheeze, and they don't necessarily have to wheeze too. Not all wheezing is asthma. So you need to really diagnose, and the physicians know how to do this. They've been doing this for a long time. So don't just jump and treat your child with asthma medications when they might have something else going on with them. Because it's very difficult to diagnose children with asthma, especially the 2 years and 3 years old group, because they can't do pulmonary function. So they developed this scale called the Asthma Predictive Index, API. And how this works is this. If you have a child at the age of 2 and 3, and they have 4 or greater wheezing episodes in the last year, and one must be diagnosed by a physician, plus their parent had asthma, or they have atopic dermatitis, or they have some kind of aeroallergen sensitivity, or they had 2 of the minor criteria, such as food sensitivity, or wheezing not related to infection, or peripheral eosinophils greater than 4%, you can be classified and identified as having asthma. So this works very simply because you cannot do spirometry with children of this age. If you wheeze greater than 4 times a year, one is them being diagnosed by a physician, and you have 1 major criteria and 2 minor criteria, they could diagnose you with asthma and treat you with asthma with proper medications. So this is a very handy tool. It's called the Asthma Predictive Index, and in case you never heard about it, that's why I brought it to you. A lot of parents wonder that if you cough, is it asthma? Or if you have a wheeze, is it asthma? How about if you cough and you don't wheeze? Is that asthma? So they really don't know. So there are some general guidelines you could use. For example, you may want to consider that the child has asthma if they have nocturnal awakenings because of cough. So if in the middle of the night, the kid wakes up 2 or 3 times a week and you hear them coughing, good likelihood it could be asthma. Also, if they cough when they're associated with exercise or play, if they're running outside with their friends, or they're playing soccer, or they're playing some other game, and they start coughing, that's another indicator. So just because they don't wheeze, don't necessarily count that they have asthma. Sometimes wheezing can be caused by different methods. For example, if one of the parents smoke, sometimes the kid could wheeze from the cigarette tobacco smoke. Also, maybe the kid has an underlying medical condition such as cystic fibrosis, or they have immune deficiencies, or they have chronic bronchitis, or they have recurrent pulmonary aspirations. There are many different reasons why a child may wheeze. Also, if you have an RSV infection, definitely going to wheeze. So you don't really diagnose asthma just based upon a wheeze. And one of the telltale signs of asthma in children is a cough, especially for the ones I just mentioned to you above. Now, the flip side of this is, are all wheezes asthma? So the answer is not all wheezes may be asthma. Sometimes wheezing can be part of an upper respiratory infection such as RSV. Sometimes many children can wheeze, but they don't develop this into asthma. If your child responds to an asthma medication and they are wheezing, that's a pretty good sign. So the point I'm trying to make here is that not all wheezes are affiliated with asthma, but you should be looking at the whole picture of the child. If they respond to a bronchodilator, if they have nocturnal coughing, if they get tired when they play any kind of sport, if they're coughing in the middle of the night, and so on and so on. So just keep in mind that all wheezes may not be asthma, and it could be, like I said before, cystic fibrosis, it could be chronic bronchitis, it could be immune deficiencies, it could be a whole host of things, especially RSV. RSV is definitely known to create wheezing in both children as well as adults. When we think about asthma triggers, there are many that you have to take in consideration, and there's basically three main categories. It could be due to an infection, it could be due to some form of allergen, or it could be due to some form of irritant. In regard to infections, RSV infections, which is very common in children, is a very good reason why a kid might have an exacerbation of their asthma attack. Also, it could be the flu, it could be sinus infections. Any of these things can be triggers to an asthma attack. In regard to allergens, there are a whole host of allergens that could cause. It could be seasonal allergens like pollen. It could be indoor allergens such as pet dander. It could be cockroaches. Many urban homes have cockroaches, and their droppings causes some form of allergic reaction by the child. It also could be irritants. Regrettably, a lot of parents smoke at home. I know a lot of parents stop smoking, and I know a lot of parents who do smoke outside, but there are people who still smoke inside. And there are also many homes. I live here in Pennsylvania. A lot of homes are heated by wood. And, wood, the smell of wood can actually be an irritant to those who have asthma. So, weather changes, if cold air can cause an asthma attack, other pollutants can cause an asthma attack. So you really got to be aware of different types of triggers for an asthma attack and try to reduce as much as you can. For example, you really can't do nothing about a viral illness like RSV or infection or so on, or getting the flu. Things happen. But you can impact, allergens such as pet dander. Regrettably, there are certain pets that have low dander levels. There are also indoor allergens. You should use a HEPA filter around your home. Maybe you should not have carpeting, and you should have hardwood floors. I know that's expensive. A lot of people can't afford it. But listen, it's your child. You got to do everything you want for it. And if you're going to smoke outside. And if you know your child has a trigger to wood-burning stoves, you're going to have to come up with an alternative heating method. So these are things you could do to prevent an asthma attack. And for example, in regard to weather changes, maybe if your child's going outside to play and it's cold weather, you give them a couple of albuterol puffs before they go outside. So this way they could be, a little bit better. They won't get as impacted from the cold weather. So these are some very common triggers. They all cause asthma, and the goal of a parent or caregiver is to reduce these allergens or triggers so that the baby does much better, or the child. So how do you make the diagnosis of asthma for a child that's less than 5 years of age? Children under 5 cannot do spirometry testing, so you can't use any of those objective measurements. So what you need to do is look at other things, such as history of the family. Does mom or dad have any kind of history of asthma? You also have to look at if the patient has recurrent episodes of coughing, wheezing, difficulty breathing. Sometimes this can occur as a result of going outside with cold air. Sometimes it could be as a result of doing some kind of activity, some play dates, or going out trying to play some kind of sport. Also, you look at night sleeping. When the child is coughing at night, or they're waking up in the middle of the night a couple of times a week, that means they possibly might have asthma. Also, you got to consider if they have any kind of allergens, like in other words, are they allergic to dust? Are they allergic to animal dander? Are they allergic to tobacco smoke, aerosols, and so on and so on? You also have to rule out that the patient does not have any kind of upper respiratory infection. So these are some of the measurements that we could use with children under 5, and we're pretty good at doing this. And once we establish that they have asthma, we could create a treatment plan. My next couple of slides will be talking about if the child is over 5 years or older, you can do spirometry, and we'll use that as well as other insights to know whether they have asthma or not. So when a child is 5 years of age or older, you may be able to do spirometry testing, and you might also be able to use peak flow meters as a way of monitoring their asthma. For example, when you do spirometry testing, basically we're looking at the forced vital capacity, you're looking for the FEV1, you're looking for the FEV1 over FVC, and you're also looking at the F25-75 to determine any kind of flow limitations that the patient may have. Typically, with obstructive diseases such as asthma, you're going to have flow limitations. Another thing you could do with this age group is that you could do a bronchodilator response study. Basically, you could do pre and post bronchodilator response. You could give them a short-acting bronchodilator such as albuterol. You could do a pre and post. According to ATS ERS guidelines, if the patient has greater than a 12% improvement at baseline or a 200 milliliter improvement in FEV1, that is indicative of a reversibility aspect, and that is a clear sign of asthma. Another good tool to use, and you could use it for basically not diagnosing asthma but determining the severity of asthma, is to use a peak flow meter. A peak flow meter is a very easy method to monitor asthma. Typically, a decline of 20 to 30% from what the patient's personal best is tells you that they have impending or current exasperation. If you have a peak flow less than 40% of their best, this indicates a severe exasperation, which means that you should get that kid to the hospital or go see the doctor. So a peak flow meter, once you have established asthma, once you have your peak flow best, this is what you do to monitor the patient on an ongoing basis to objectively evaluate how severe their asthma is and what kind of guidelines you should do. So this is a simple little process to do with patients. And remember, 5 years and older, they can do spirometry. And also what you're looking for is airway reversibility with a bronchodilator response. There is some additional testing that can be done with these patients. Basically, you could do a provocation testing which basically, if you feel that the patient has asthma, they are wheezing, they are coughing, but they have normal spirometry, basically what you want to do is some kind of bronchoprovocation testing. And this could determine whether they have a reactive airway. Another test you could do is exercise testing. A lot of patients have exercise-induced asthma. That means that if the patient does any kind of activity, they end up being short of breath, wheezing, and coughing. A positive test shows that if you have a decrease in your FEV1 greater than 15% from baseline, that is a positive test. Possibly with these kind of patients, you may want to use a short-acting bronchodilator, give them a couple of puffs before they engage in any kind of sport. Then you have your methacholine challenge. I'm sure you're all familiar with that. Basically, a positive test is a reduction in FEV1 greater than 20% from baseline. This is a test to rule out asthma, but you have to be a little careful with this test. And finally, we get into allergy testing. A lot of times, triggers for asthma can come from mold, mildew, dander, dust mites, cigarette smoke, perfumes, everything. You may at this point want to do some blood testing and looking at the IgE levels to see if they really are having some kind of allergic response to some form of allergen. So these are additional tests you could do, different methods you could do with the patient with asthma. And now we're going to get a little bit more into how do you manage these patients. So if you have a child that you identify as having asthma, what is your role as a caregiver to this child? When I say a caregiver, you could be the parent, you could be a sibling, you could be an aunt, you could be an uncle, you could be a close relative. So you have a child who has asthma. What do? How do you manage it as a caregiver? Basically, you have to identify the severity of the asthma with the patient, and you'll know this as we go a little bit further on in this lecture. So now that you know the severity of this child and you know their norm, you have to also recognize their current medication management. So basically, there's a stepwise type of interaction with a child who has symptoms that are flaring up. So if they have no kind of flare-ups, you just keep the current medication going. But if they show exacerbations of asthma, you have to step up the medication for them. And a lot of times this could be based upon peak flows. I mentioned this earlier on the previous slide. You could know what a normal peak flow for that child is. And if you start seeing the child going down by 30% or from baseline, you need to step up the medication regimen. Also, you need to monitor the symptoms of the patient. You have to sort of get used to their wheezing. You have to understand if they start coughing at night. So the most important thing you could do to control asthma, what they call asthma control, is the use of peak flows. Peak flows can determine where you are when you're on a good day. When you are normal and your peak flow is X amount, and all of a sudden you see a 30% decrease in that, that is time to step up. So as caregivers, we really have to be educated on the management of children. We need to understand the stepwise increase in medications if they show symptoms. You have to recognize if they're getting worse. So all of these things really help. The more you're educated, the better the patient will be. The more the patient is educated, the better. It's very objective. You do a peak flow, you see it go down by 30%, you know you got a problem. If you see it go down by 40%, you got a bigger problem. So understanding our role as caregivers is really important with the management of these kids, and it could save lives. So it's up to you to know their symptoms and know how to monitor their ability each day with their asthma. Not all asthma is the same. Some people have very mild asthma, some people have very severe asthma. So to classify asthma, to know the severity of it, to know exactly how to treat it, you need to identify what type of asthma you have. More importantly, what kind of range of asthma do you have? The National Asthma Education and Prevention Program has classified asthma into 4 stages: intermittent, mild persistent, moderate persistent, severe persistent. Based upon your classification, you will have a certain treatment modality. And also, you may be identified as mild persistent, but you might have an exacerbation over time and work yourself up to moderate persistent, where you need a new treatment regimen. So this classification, I'm going to go a lot more detail exactly what it is, how do they measure it, and I'm also going to, more importantly, how they treat it. So just understand, asthma is not just a one-stop asthma. Basically, you have different classifications, and you should know these classifications and should know the treatment options for each type of classification. And remember, you may not just stay in the same classification for your whole life. It may change over time. So let me go a little bit further on the next few slides. As I was mentioning on the previous slide, asthma is classified into different types of groups. And the reason for that is if you are a newly diagnosed patient with asthma and you go to the physician and they do an assessment of you, they do a history of you, they might even do a pulmonary function testing on you, based upon that initial classification with the physician, you will be based upon either having intermittent asthma, mild persistent asthma, moderate persistent asthma, or severe persistent asthma. And based on that classification, you will be given a treatment regimen. And that treatment regimen may be based upon your symptoms. And that means that you're going to be taking certain medications on a daily basis to control your asthma. Now, over time, these classifications may change. And also you have to understand you might have flare-ups during these stages. So in other words, you might be taking your typical medications every day, but all of a sudden you have a flare-up. That means you must increase your medications to get yourself under control. So remember that your classification is based on your initial assessment with the physician. That classification may change over time. Typically every 3 months of the 6 months, the doctor will reassess you and see if you still are in that same classification. As I was saying to you, children under the age 4 and under are hard time to diagnose because they do not, you cannot do typically spirometry on them. So what you really have to do is based on symptoms. Symptoms of nighttime awakening, cough, wheezing, and so on. And you have to rule out any kind of allergies. So remember, classifications are set on the initial assessment with the doctor. These classifications are reassessed every 3 to 6 months. You might have a flare-up during any of these classifications. That means that you may have to increase your medications during this time. So I just wanted to further give you an example of classifications. Now we get into a very important part of this presentation, and that is asthma classification. Remember, when a patient comes in for the first time to see a doctor and is assessed, they are classified as either mild intermittent, mild persistent, moderate persistent, or severe persistent. And based upon their classification, they will get a treatment program for them. So let me give you a little bit more details about how this works. The National Asthma Education and Prevention Program has developed this system of mild intermittent, mild persistent, moderate persistent, and severe persistent. And basically, it's based upon symptoms. And these symptoms can change over time. So sometimes you need to be reclassified over a period of time, like 6 months normally. Any person in any category can have a severe asthma attack. So I just want to get that out. With children under 4 years of age, it's very difficult to diagnose. But let's talk about someone who's the age above 4, like 5 years in age over. So let's talk about intermittent asthma. The symptoms for intermittent asthma are, when we talk about symptoms, we're talking about difficulty breathing, we're talking about wheezing, we're talking about chest tightness, and we're talking about coughing. They will occur less than 2 days a week. So they'll have any of those symptoms less than 2 days a week. It does not impact their normal activity. They sometimes may have some nighttime symptoms, but it does not, it's less than 2 days a month. And when you talk about lung function, their lung function is really normal. So all their peak expiratory flow rates are normal, and that is a normal person who's on intermittent asthma. Now let's talk about mild persistent. With mild persistent, the symptoms occur more than 2 days a week, but not every day. Sometimes their asthma attacks can interfere with the daily activity. Nighttime symptoms occur anywhere from 3 to 4 times a month. And also lung function for them, typically their peak expiratory flow rates are around 80% as predicted, but their PEF can vary at times, sometimes in the morning and the afternoon. Now let's get into moderate persistent. Moderate persistent means that they have symptoms daily. Basically, they need to take a short-acting bronchodilator every day. Their symptoms interfere with their daily activity. Nighttime symptoms occur more than 1 time a week. And also, but it doesn't necessarily happen every day. And then lung function tests, the PFT tests, are abnormal. Basically, they're greater than 60% of their peak expiratory flow rate, but less than 80%. And the peak expiratory flow rate can vary from morning to afternoon. Now let's get into the final category of severe persistent asthma. What happens with this group, they have every day they have symptoms throughout the whole day. So it's just not a morning, night thing. They are short of breath, they're wheezing all day long. Their severity of their asthma limits all kinds of physical activity. Their lung function tests are typically less than 60% as predicted, and their peak expiratory flow rates can vary during the day. So based upon the classification they are, you will come up with a treatment regimen. And so this is reassessed every 6 months. So these are the basic understandings of how to classify asthma. I'm not going to get a lot into the treatment plan, but the most important part that I want you to remember, that is based upon your classification, you have a regimented treatment plan. For example, as I mentioned on the previous slide, if you have mild intermittent asthma, all you got to do is take a albuterol PRN, a beta agonist PRN. You know, you don't have symptoms that often, so that'll be all you need. If you have mild persistent, you could take a low-dose corticosteroid, or you could take singular, and then you need to take albuterol PRN. So what that means is, if you have mild persistent asthma, you're not going to take Q4 albuterol or Q6 albuterol. What you are going to do is be maintained by a low-dose corticosteroid to reduce the inflammation, or you'll be on singular. Either way, you may take an albuterol PRN, but you're not going to be taking albuterol as a rescue medication, because you're going to be managed properly with the corticosteroids or singular. When you get into the higher levels of asthma, such as moderate persistent, then you need either a low to medium dose corticosteroid. You may also have a long-acting beta agonist, and this is your treatment plan. And you could also take an albuterol PRN on top of that. The key point here is you need to address the inflammation of the asthma, and the corticosteroid can do it. If you have severe persistent asthma, you're going to need a high-dose inhaled corticosteroid, a long-acting beta agonist, and you might want to consider taking some oral corticosteroids with flare-ups. Here's the problem with people with asthma. If you are diagnosed with moderate to persistent asthma and you've been taking low to medium dose corticosteroids for a while and the inflammation is under control, you think you're cured. So at this point, you back off on your corticosteroids, and then what happens is the inflammation comes back. When you have asthma, typically asthma is a lifelong illness, and you need to address this long term. You can be reassessed for your what category you're in. You could be mild, intermittent, mild, persistent. You may go from one category to another, but this is typically addressed anywhere from every 3 to 6 months. So when you get a regimen of medications, you got to keep to it, because that is what causes hospitalizations. People stop taking their corticosteroids, they don't take it at all, they go back and taking albuterol as a fix for everything, and then they end up getting this severe inflammation and brought to the hospital. So if you're diagnosed and you know what category you're in, and you know what kind of treatment regimen you're on, take that treatment every day, and also reduce triggers. This is the basics of care for asthma. How do you identify if you have either persistent or intermittent asthma? Consider the diagnosis of persistent asthma if you have symptoms greater than 2 days a week, you have nighttime awakenings greater than 2 times a month, you also have hospitalizations where you have to go on oral steroids at least 2 times a year, your FEV1 is less than 80%. Now, if you're a child and you're greater than 5 years of age, what you're looking for if you have persistent asthma is your FEV1 over FVC is less than 80%. And if you're a child between the ages of if you're a child between the ages of 8 and 19, your FEV1 should, if it is any less than 85%. So this is how you could tell the difference between intermittent asthma and persistent asthma. And all the themes up here talk about persistent asthma. So let's say you have your classification of asthma, you have your treatment regimen, and the issue is if you continue to take your medication as planned and you do not have any kind of flare-ups, your asthma will be controlled very well. But that's not the real world. The real world is people stop taking their medications for various reasons. So to do that, we need to keep people who are in a certain category, say mild persistent or moderate persistent, we need to keep them well controlled. We don't need them to be not well controlled, and we surely don't want them to be very poorly controlled. We want them to be well controlled. So no matter what classification you're in, we want you well controlled. So what is the definition of well controlled? Well controlled means that you have less than 2 days a week of daytime symptoms, then you can normally take a bronchodilator. Nighttime awakenings, less than 2 times a month. Limitations on any kind of activity, none. How about the use of short-acting beta agonist? Less than 2 days a week. How about your asthma control test, ACT? That means you need to have a score greater than 20. I'll get a little bit more into that later. And then you have less than 2 times a year of taking oral prednisone. And you also, at the time, your peak expiratory flow rate, your FEV1s are greater than 80% as predicted. So if you're well controlled, that is what you have. When you start getting into not well controlled, that means you have greater than 2 days a week of symptoms. You have nighttime awakenings 1 time to 3 times a week. You have some limitations on your physical activity. You need to take a short-acting beta agonist greater than 2 times a week. Your asthma control test has a score of anywhere from 16 to 19, and that means that normally you need to take prednisone greater than 2 times a year. That's not well controlled. And if you're very poorly controlled, you have symptoms throughout the day, you have greater than 4 times a week nighttime awakening, you are extremely limited in your physical activities, you take short-acting beta agonists several times a day, and your ACT score is less than 15. So, and then the course of prednisone is greater than 2 times a year. So the bottom line is, based upon your symptoms, you're going to be categorized in your asthma control. And what we want you to be is well controlled. We don't want you to flare up and go into not well controlled, and certainly don't want you to be very poorly controlled. So we want you to stay in the category of well controlled, like I mentioned before. So let me give you a little bit more detail. I want to reiterate what is well controlled asthma. Well controlled asthma is that you have daytime symptoms less than 2 times a week. Your nighttime awakenings is less than 2 times a month. You could perform all kinds of physical activities, playing a little sport, play a little soccer, play a little baseball, run, whatever you want to do, you can do. You have less than 2 steroid bursts a year. What that means is that you're not on oral steroids for less than 2 times a year, that your FEV1 is greater than 80% of predicted for those that can do PFTs. And if you can do a PFT and you're at the ages between 8 and 19, your FEV1 over FVC is 80% or 85% for the 8 to 19 group. So also, there's a term called stepping up regimen and also stepping down. In other words, if your symptoms flare up, you need to maybe possibly step up on your treatment regimen, and once you get balanced, you could step down. The point is you need to do this for about 3 months and then reassess every 3 to 6 months. So this is what the gold standard is. We want you well controlled. So I just explained to you why you want to have everyone on a well-controlled plan. Why do people fall off the wagon? Why do they flare up? I mean, there's other reasons. You could get a viral infection or a bacterial infection, but a lot of times the reason for flare-ups is that you have a severe asthma attack, you go to the doctor, they give you a treatment plan, you feel better, and then all of a sudden you're non-compliant with the medications. You don't want to take the medications. You just want to take a short-acting beta agonist. You don't want to take your corticosteroids. So what happens is the patient or the parent are non-compliant and don't understand how medications work. So another problem why things lack control is that patient education is not done appropriately. It's really important to teach them how to use a nebulizer, how that all kinds of meter-dose inhaler should be done with a spacer, how to use a DPI, how to use a twist inhaler, how to accurately measure your peak flows. You know, if you have a peak flow meter and you're measuring your severity, how you feel, this is a very objective way of doing it. Also, you got to make sure that the patients have an asthma action plan detailing all the types of medications they have and when they need to take it. And also, if they have any kind of flare-ups, to escalate their treatment plan, and as they start getting better, de-escalate it. Also, a new action asthma plan is actually assessed every 6 months or anytime there's a change in medication. So the bottom line, why people stay not in control is basically it's more human error, and most of it has to do with education. People just don't get it. You need to ensure that the patient who's on a regimen take this regimen every day and they be well controlled. I wanted to share with you a system called Asthma Control Test, ACT. ACT was developed to be self-administered by the patient to determine whether their asthma is in control. Asthma is not a fixed disease process where it stays steady every day exactly the same. There are times when your asthma can flare up, or there are times when it's well controlled. So if you could self-administer this test and you could come up with a numerical score, it's very good for the patient to understand what's going on with themselves. For example, what you do in this test, you ask these 5 validated questions. They've done this survey with many patients, and it's really accurate. It's valid, it's reliable, and it's been tested and tested. So, for example, in number 1, in the past 4 weeks, how much time did your asthma keep you from getting as much work done at school or at home? So The lower the score, the worse. The higher the score, the better. So if you got 5s for everything, you would be in really good shape and your asthma is well controlled. But if your answer is number 2, for question number 1, you do number 2, you put 2 in the score. Then during the past 4 weeks, how often did you had shortness of breath? And if you said not at all with a number 5, that would be your best response. And if you say once a day, that would be number 2. So you would put a 2. And then you would do the third question. During the past 4 weeks, how often did your asthma symptoms, wheezing, coughing, shortness of breath, chest tightness, or pain wake you up at night? So in other words, did you have nighttime awakenings, or you were really like waking up earlier in the morning than you're supposed to? If you said 2 to 3 nights a week, again, your answer is number 2. The best answer is number 5. So the point of this test is that if your score is 19 or greater, that means you are having your asthma under great control. So the ultimate score you could get is 19 or above. If you get less than 19, this is going to go into our next few slides we're going to talk about. So suppose your asthma control is not good. You are having wheezing during the week. It's impacting your work, your shortness of breath. You have nighttime awakenings. And you're on some kind of asthma regimen, but it's not working. So there's a time to move on that, and I'm going to show you in the next few slides. So the magic point of the asthma control test, if your score is 19 or greater, you're in good shape. If your score is less than 19, you got to do something, and I'm going to talk about that in a few slides. As I mentioned earlier, asthma is not a fixed disease. In other words, once you are diagnosed with asthma, once you get a treatment regimen set up by the doctor and you're compliant, you do the right thing. But sometimes asthma has flare-ups. So a lot of times patients who control their asthma very well will have a stepwise approach to managing asthma. So what do I mean by stepwise approach? Stepwise approach means that if you're on a regular regimen of medications and you are well controlled, you don't have to do anything. But suppose you have flare-ups, suppose you have symptoms. What that means is you have to step up your treatment regimen. And a lot of times doctors and patients work very closely together to do that. So for example, if you have intermittent asthma, your normal treatment regimen is typically a short-acting beta agonist PRN. So, you get a little treatment. But if you have symptoms greater than 2 days a week, then you really need to say that my asthma is not controlled, that the intermittent short-acting beta agonist is not enough. So rather than go to the doctor or the emergency room, you should step up your treatment with the knowledge the doctor knows what you're doing. So if you are diagnosed with intermittent asthma, you typically take an albuterol PRN, but now you're having symptoms greater than 2 weeks. The next step to do is actually to step it up to step 2. This is step 1 right here for intermittent asthma, but if you have a flare-up, you have to go to step 2, and I'll show you step 2. As mentioned in the previous slide, you have a flare-up, and so at this point, when you have symptoms greater than 2 times a week, maybe you have to introduce a low-dose inhaled corticosteroid, such as Pulmicort, Flovent, Qvar, etc. You also may want to introduce a leukotriene blocker, such as Singulair. Again, if your asthma symptoms, even with this particular regimen, is worse, and you're having more flare-ups greater than 2 days a week, you might have to step it up again. Now, stepping up and stepping down is tolerated, is acceptable. So, but at this point, you're having symptoms greater than 2 days a week. You upped your dosage to including a low dose of steroid inhaler. Also, you might have introduced some Singulair leukotriene blocker. but you're still having symptoms, at that point, you're going to go to step 3. Step 3, at this point, you're on a low-dose inhaled corticosteroid, you're on a leukotriene blocker like Singulair, or you might up your dose to a medium-dose inhaled steroid, or you could go to a low-dose inhaled steroid with a long-acting beta agonist. So the point what I'm trying to say to you is that asthma is not stagnant. It's not a fixed thing. So as your symptoms get worse, you step up your medication regimen. Once you get well controlled for like 2 to 3 weeks, you could step down again and go back to the previous settings. So the point with this is it's a self-administered titration of medications that go up and down based upon your symptoms, and understanding and utilizing a stepwise approach to managing your asthma is a really good thing. One of the most handy tools to use if you have asthma is a peak flow meter. A peak flow meter is very easy to utilize. You could also have it color-coded to different zones, how you're breathing. For example, if you have a peak flow meter and you typically do 300 every time, when you're well managed, you get 300, 300, 300. Without a problem, you get 320. So you would call that your green zone. In other words, it's between 80 to 100% of your personal best. Now, suppose you get a flare-up of asthma, and as a result of the flare-up, your peak performance goes down to 50 to 80%. So that's giving you a warning sign that, there's something going on with me that I really need to get a better handle on my asthma. Maybe I should use that step-up approach, that stepwise approach that I mentioned earlier. And so when you go from green to yellow, there's a possibility that you need to step up on your medications just so that you can manage to get back into that green zone. Now, suppose you do your peak expiratory flow rates, or your peak flows are in the range of less than 50% of personal best. They are below 50%. That's the red zone. What that means is maybe you better take your child to the doctor. Because in other words, we can manage the yellow zone at home. When you get into the red zone, you don't negotiate at this point. Maybe the kid needs some oral steroids. You need to sort of really step it up, and you may not be able to self-manage this like you could the yellow zone. So a peak flow meter is a great tool to use with these patients. With children as well as adults, a lot of times children are very active in sports. You want your child to play soccer, you want them to play a little baseball, whatever you like them to do. A lot of times patients who have asthma have what is known as exercise-induced bronchospasm, or exercise-induced asthma, EIB or EIA. It happens to a small population of patients who have asthma where they're well controlled, but all of a sudden when they participate in some kind of physical activity, such as running or doing anything like that, they end up having bronchospasm. So the goal of children with exercise-induced bronchospasm or exercise-induced asthma is to manage their asthma to a point where they can engage in sports, run around, have a fun just like anyone else. So I'm going to go a little bit, give you a little background on this. With exercise-induced asthma, there are some general principles that you got to follow. First of all, if you are having some kind of asthma flare-up or bronchoconstriction as a result of participating in a sport, that means you're not being managed properly. So you need to do some adjustments. So for example, a child may be asymptomatic on the current regimen, but when they engage in some kind of sport, they actually get bronchospasm. So the goal is to improve their normal activity level to a point that they can compete in sports. And every child is different. There's no cookie cutter dosing or anything like that, but every child is a little different. But the child really has to understand that under normal conditions, their asthma is well controlled. But when they engage in sport, they actually get bronchospasm. So a lot of times these children are given medication regimens to do prior to the sport activity. So what happens is, you have a child who's feeling good, but he's going to be engaging in sport that afternoon. So you might want to give some kind of therapy to that child prior to the sporting event. And I'm going to get a little bit more details about this in the next slide. So how do you diagnose someone with exercise-induced bronchospasm? Normally, they have a normal PFT at rest. So they really have no kind of asthma flare-up at rest. Actually, you actually rule out any other kind of stimulus for bronchospasm, such as perfume or maybe food allergy and so on. A lot of times these patients have allergic rhinitis. So that is a common finding with a lot of patients who have exercise-induced bronchospasm. So how do you do it? So what you do is you bring the child to a doctor, they do a pulmonary function test on the kid, and what they look at as a 10% decrease in FEV1 after 8 minutes of exercise at 90% maximum predicted heart rate. So what that means is that the kid is engaged in some kind of running activity, maybe a treadmill, maybe a bicycle. They do this for about 8 minutes. Their heart rate goes up to 90% of the maximum predicted heart rate, and they have a 10% decrease in FEV1s. That is the hallmark diagnosis of exercise-induced bronchospasm. So what do? A lot of times they take a beta agonist before exercises, or they can actually start taking a leukotriene receptor antagonist prior to any kind of sport, such as Singulair. So, it's easy diagnosed, it's easily managed. There's no reason why your child should not enjoy all the things that other children enjoy, and you just gotta educate the child as well as yourself on what to do with this. I want to thank you for joining my presentation, and this is our summary slide. So remember, asthma in children can be controlled. It takes a little effort, but you have to understand what kind of symptoms a child has. You need to know what kind of medication management to start the child on. You also need to understand that if they have exercise-induced bronchospasm, what to do. So the point is a very simple way to monitor the child on a daily basis is to do peak flows. And other ways of measuring compliance, just because you're feeling better doesn't mean that you stop your regimen. Asthma is a lifelong disease. Some people grow out of it, but the best thing to do at this point is make sure that you're compliant. There's what they call a step up and step down approach every 3 months. What that means is if you put a child on a certain regimen of medications, you could reevaluate the child every 3 months to determine whether that's working. And if they are doing very well, you might want to step down on the medication. But if they're not being managed very well, you may want to step up. Remember, kids are kids. They are forgetful. They don't want to do things. They're stubborn. They want to engage in sport. So it's up to you to work with your child and make them understand what's going on with asthma and how to manage it. And the daily peak flows is a great tool. And most importantly, watch for allergens and watch for irritants. Identify if the child has any kind of irritants to certain chemicals or around your house or carpeting, and make sure your allergens are understood, that they don't have food allergies, they don't have rhinitis, and so on. And if they do, you manage it. So these are the summary slides. Kids should have fun in their life. They could have fun even with asthma, and they have to be a partner with the patient, not the patient. They have to be a partner with the parent to understand how to manage this. I want to thank you for all joining me, and this is our reference page. So, There's a lot of good references. Asthma guidelines change year to year. I had some slides in there that were a little bit dated, but the change is really minor, minor, minor. So if you're looking to do a little bit more research on asthma control, especially with the pediatrics, this is a good guideline to start. And I want to thank you all for joining me.